Welcome to Lesson 3, where we will discuss borderline personality disorder. And the verse guiding this lesson is from Philippians 4, verses 6 and 7. Do not be anxious about anything, but in everything by prayer and supplication with thanksgiving, let your requests be made known to God. And the peace of God, which surpasses all understanding, will guard your hearts and your minds in Christ Jesus. The diagnosis of a personality disorder is not typically made in adolescence. However, some adolescents may present with traits of various personality disorders. One particular personality disorder is more often diagnosed in the adolescent population, and that is borderline personality disorder. Borderline personality disorder and personality disorders in general have quite a stigma. Previously, under the DSM-4, personality disorders were considered an Axis 2 diagnosis, and if a patient was being difficult in any psychiatric setting, staff could pejoratively state, oh, they're an Axis 2. And so certainly it is true that individuals with a personality disorder can be very difficult and have challenging behaviors, but it's important to understand the underlying root of those behaviors. Borderline personality disorder has long been to psychiatry what psychiatry has been to medicine, a subject of public health significance that is underrecognized, undertreated, underfunded, and stigmatized by the larger discipline. As with psychiatry and medicine, this is changing. This is changing greatly today. Thank God we have more attention on the need for quality mental health treatment. New knowledge, new attitudes, and new resources promise new hope for all patients with mental health disorders, but also for patients with borderline personality disorder. A Girl Interrupted is an excellent, actually, it's available as a book or a DVD that portrays an adolescent female with borderline personality disorder. So I do encourage you, if you have not yet seen it, to go ahead and watch this, as it will really illuminate the characteristics that we will be discussing here regarding this disorder. And here are the criteria for the diagnosis of borderline personality disorder. And we can see there are 4 different dimensions. One of the requirements for a diagnosis of borderline personality disorder is that they need to have a history and pattern of unstable relationships in a number of different contexts. And so if we look at the emotional domain, so of these criteria, the individual needs to have at least 5. And in the emotional domain, we have affective instability due to remarked reactivity of mood, with intense episodes of dysphoria, irritability, or anxiety that can last from a few hours or a day or 2. Chronic feelings of emptiness and inappropriate, intense anger or difficulty controlling anger, such as frequent displays of temper, constant anger, and recurrent physical fights. In the cognitive domain, we have 2 symptoms, including identity disturbance with marked and persistent unstable self-image or sense of self, as well as transient stress-related paranoid ideation or even severe dissociative symptoms. In the impulsive dimension, we have impulsivity in at least two areas that are potentially self-damaging, such as spending, sex, substance abuse, reckless driving, or binge eating. As well, under impulsivity, you can have recurrent suicidal behavior, gestures, or threats, as well as self-mutilating behaviors such as cutting. And under the interpersonal dimension, frantic efforts to avoid real or imagined abandonment, and a pattern of unstable and intense interpersonal relationships characterized by alternating between extremes of idealization and devaluation. We also see splitting behaviors here as well. So we don't have real clear statistics regarding epidemiology. According to the textbook, adults are estimated to have between anywhere from 1 to 6%. And in the US, it has been identified as high as 6.4% in the general medical population and 20% in inpatient psychiatric patients. A French study identified 10% in boys and 18% in girls. It definitely has a higher prevalence in females. A Chinese study identified prevalence at only 2%. Some studies have postulated that there is actually a similar prevalence between the genders in general population. However, females have been identified as more frequent than males in clinical samples. There can be a significant burden of illness on families. Um, One observational study of mothers with borderline personality disorder identified the mothers as being less available, having poorer organization of their behaviors and moods, and lower expectations of positive interactions. Borderline mothers were noted to be more often overprotective or intrusive, as well less demonstrative and less sensitive to the child's needs. Technically, one should diagnose only after age 18. Prior to age 18, frequently the diagnosis of traits would be given, borderline personality disorder traits. Uh, Sometimes, if the symptoms are very clear and persistent, then the diagnosis may be assigned. The peak of frequency of symptoms, of onset of symptoms, has been identified as early as 14 years of age. 80% of teens with borderline personality disorder have a personality disorder in adulthood, but only 16% actually have borderline personality disorder. So whether that is due to some misdiagnosis as well as the effectiveness of intervention and therapy, I don't know, but I believe both of those have an impact. Some follow-up studies have shown a remission rate of 74% after 6 years and identified that 88% of individuals diagnosed with bipolar disorder remit after 10 years. There usually are two clusters of symptoms, the anger and abandonment issues, as well as self-harm and suicidality. The risk of suicide is definitely higher in an individual with borderline personality disorder and can be anywhere as 4 to 10% higher risk, especially during the ages of 30 to 37 years. It is rare during treatment, but more common with an untreated disorder. Impaired functioning is definitely associated with borderline personality disorder and can even be worse than other personality disorders and worse than depression. These individuals often have a pattern of frequent job losses and unstable relationships, as well as being the victim of sexual assault. There are several developmental theories that have been used to understand and guide treatment for individuals with borderline personality disorder. Some of these hypotheses include that of object relations theory. Otto Kernberg is the theorist who has done a lot of writing in this area. And of course, attachment theory is very significant with theorist John Bowlby. Marsha Linehan's emotional dysregulation theory is one of the most common used to guide treatment today, and she is cited with the development of dialectical behavioral therapy, or DBT, which is a further development of cognitive behavioral therapy to include dialects or uh, ways of processing both thoughts and emotions. And cognitive theories, as well as chronic childhood trauma theories, are implicated as well. All of these hypotheses stress the individual's poor emotional development during childhood, often scarred by trauma and emotional deficits, with failure to adapt to the child's needs. And so risk factors include childhood trauma, sexual abuse, early maternal separation, neglect, and genetics as well. It has been identified that heritability can be as high as 47%. And again, with that, we do have some nature and nurture influences going on here. So, when to make the diagnosis? Certainly, we do see quite a bit of self mutilating behaviors going on in adolescence today. And not all adolescents who self harm have borderline personality disorder. The main characteristic is the emotional instability and impulsivity, and it is a pervasive behavior pattern. It does usually begin in adolescence or early adulthood. There are some subtypes, which include dependent, where the individual have ambivalent, unstable relationships, or an impulsive type, where there's impulsivity in multiple areas that can include breaking the law. And a borderline subtype has extreme emotional instability with a disturbed self image. Presenting symptoms that you will often see include substance misuse, mood swings, abnormal eating, and self harm. And we have a number of comorbidities that include depression, anorexia, bulimia, alcohol use disorder, or other substance use disorders, as well as ADHD. An individual can also have more than one personality disorder. And so we have comorbidity rate with antisocial personality disorder at 22% and avoidant personality disorder 21%. There are a number of tools that can be used for assessment, such as the structured interview for the diagnosis of DSM-4 personality disorders and the structured clinical interview for DSM-4 and the International Personalities Disorder Examination. The diagnostic interview for borderline revised is another tool, as well as the McLean screening instrument for borderline personality disorder. The child and adolescent psychiatric assessment also includes screening for personality disorders, and the PDQ or Personality Diagnostic Questionnaire is the most popular. And take a look at the treatment guidelines, as the APA has some clinical practice guidelines that are very helpful to inform practice in this area. In the inpatient setting, it's important to treat all comorbidities and to really focus on crisis management. The development of a detailed safety plan is imperative. There really is no data on the effectiveness of inpatient treatment specifically for borderline personality disorder. Certainly, crisis intervention, treatment to manage suicide risk, substance use disorder, or self harm may be needed, but it has been postulated that inpatient treatment can contribute to additional traumatization and have a risk of regression. So, outpatient treatment certainly is preferred. Obviously, we always want to treat our patients in the least restrictive environment. And what's important in the outpatient setting is to have an individual clinician, a therapist, to develop a therapeutic relationship and learn to develop trust and can be a very important part of healing. Day treatment is also a possibility, and support at school. Many organizations do have therapists who can go into the school to meet with the students during the day, and that certainly can be beneficial. And so the treatment plan should certainly be collaborative. Really want to get buy-in from the patient and have them help to set the treatment goals and monitor their progress. They appreciate frequent feedback, positive reinforcement as much as possible. And certainly, crisis management is important. Progress towards long-term work is usually what is needed for personality disorders. The adult caregivers need to be involved in the treatment as well and active in participating in the safety planning and harm prevention. We do not have any medications that are effective for borderline personality disorder. Medication is usually used to treat the comorbid disorders, not for the borderline symptoms. Sedatives should not be used for more than a week. As well, antipsychotics can have short-term benefits. And, when there is that cognitive perceptual symptom activation of paranoia from extreme stress or anger and irritability and aggression or mood lability. They may help, again, though, only on a short-term basis. Remember, substance use disorders or substance misuse are a constellation of symptoms and problems that go along with borderline personality disorder. So we really want to be mindful about using psychoactive substance for symptom management. So the clinical practice guidelines identify psychotherapy as the first line of treatment. And CBT and DBT both have good evidence supporting their use, and there are a number of protocols that have been developed using these approaches. Psychoanalysis is important. It again helps to identify the underlying psychological uh, difficulties and attachment or developmental problems as well, helping the individual through that dichotomy of black and white thinking, that you're either good or bad, it's all or nothing. And so that is the area that dialectical behavioral therapy is very good at. Splitting is emphasized, helping to identify when that is occurring, and more frequent therapy is often needed, having sessions twice a week, and a lot of focus on transference, because remember, we're talking about using the relationship as part of that healing process. So we're going to be talking quite a lot about how the patient is feeling about us as the therapist, and working through those feelings with them. And so, just another uh, area to reinforce the need for good psychotherapy skills for psychiatric mental health nurse practitioners, because here we have a disorder where medication is not going to be helpful, and the healing is in the relationship. And so, it's important for us to use all of the tools in our toolbox as psychiatric nurse practitioners.